Okay, so morning everybody. We start with the second part, that is we were done till question 71. This gets us to the next question, that is question 72. This gets us to question number 72. What is true about ANA? Anti-RNA antibody is specific for SLE? No, this is false. Next, double-stranded DS anti-DNA is specific. Yes, the second statement is true. Next, ANA normally is present in 80%. No, that is also false. So the answer is B. 72. The answer is B. That is double-stranded anti-dsDNA antibody. Double-stranded anti-DNA antibody. Anti-DNA antibody is specific for lupus. This is the true statement. This is the true statement. Next point. So before we go further, let us have a look at antibodies seen in lupus. First point, most common or most sensitive antibody. Most common or most sensitive is ANA, anti-nuclear antibody. Next point, most specific. Most specific, this is important, please put a star on this. Most specific is anti-Smith. Anti-Smith, S for specific, S for Smith. See, there is never a confusion about most sensitive, but most specific, anti-Smith, followed by anti-dsDNA antibody. Followed by anti-dsDNA antibody. So most specific. Next point, drug-induced lupus. Next point, drug-induced lupus. It is associated with anti-histone antibody. Drug-induced lupus, anti-histone antibody. And last is neonatal lupus. Neonatal lupus with congenital heart block. Neonatal lupus with congenital heart block. It is associated with anti-Rho/LA antibodies. Anti-Rho/LA antibody. Neonatal lupus with congenital heart block. Next, this is a standard set of questions that are being asked since the time I was sitting in your chair. So, next point, this gets us to the new set of questions that are asked with this, that is patterns of immunofluorescence with ANA. An extremely important topic, patterns of immunofluorescence with anti-nuclear antibody. ANA, it shows four main patterns of immunofluorescence, which are homogeneous, or the diffuse pattern. Homogeneous or the diffuse pattern, which is associated with antibodies against chromatin and histones. Which is associated with antibodies against chromatin and histones. Homogeneous or the diffuse pattern. The next pattern is speckled. Next is speckled, which is the most common but least specific. Most common but least specific. First point. Next point, speckled, what does it denote? Speckled pattern, it reflects the presence of antibodies to against or antibodies to non-DNA nuclear constituents. Wait, let me just correct the magnification slightly. Okay, so it reflects the presence of antibodies to non-DNA nuclear constituents. What do we mean by this? That is, examples are Smith antigen, ribonucleoproteins, SSA and SSB antigens. SSA and SSB antigens. So speckled, it is the most common but least specific and has antibodies against non-DNA nuclear constituents. Non-DNA nuclear constituents. Next, the next pattern is the nucleolar pattern. The next is the nucleolar pattern. Nucleolar pattern, which is associated with few discrete spots, which shows the presence of few discrete spots against RNA. Against RNA, few discrete spots seen against RNA, seen in systemic sclerosis. Seen in systemic sclerosis. Now, systemic sclerosis, it is of two types, limited and diffuse. Limited type is associated with anti-centromeric antibody, whereas diffuse type is associated with anti-RNA polymerase 3 antibody. So, nucleolar pattern has few discrete spots against RNA. So, systemic sclerosis, diffuse type. Associated with systemic sclerosis, diffuse type. Whereas the last pattern is the anti-centromeric pattern. Last is the anti-centromeric pattern, which has antibodies against centromeres, seen in Sjogren's syndrome. Seen in Sjogren's syndrome and systemic sclerosis. Sjogren's syndrome and systemic sclerosis, limited type. Seen in Sjogren's and systemic sclerosis, limited type. These are the patterns of immunofluorescence. These are the patterns of immunofluorescence with ANA. Next, this gets us to the next question, that is question 74. This gets us to the next one, that is question 74. Let us have a look at this. No, my mistake. I guess we have skipped question 73. Let us first have a look at question 73. All of the following is true except NADPH oxidase acts via superoxide and ions. True. We have already seen the pathway of NADPH oxidase. Oxygen is converted by NADPH oxidase to superoxide. Superoxide dismutase H2O2 and MPO and stuff, leading to hypochlorous anion. So the first statement is true. Next, Shidiak-Higashi syndrome is due to defective phagolysosome formation. True. The main defect in Shidiak-Higashi is defective phagolysosome. As a result, it has giant granules and neutropenia. We'll be writing that. Third, in Bruton's A-gamma globulinemia, opsonization is not affected. This is false. It is affected. Next, MPO action is mainly due to hypochlorous anion. Fair enough. So, question 73. Question 73. The answer is C. That is, in Bruton's A-gamma globulinemia. In Bruton's A-gamma globulinemia, opsonization is not affected. Opsonization is not affected. This is the false statement. This is the false statement. So before we go further, let us have a look at each of the statements one by one. NADPH oxidase acts via superoxide anion. This is true. Oxygen is acted upon by NADPH oxidase, in turn leading to the formation of superoxide anion, which is then converted by the action of superoxide dismutase to H2O2, further acted upon by myeloperoxidase and chloride, leading to hypochlorous anion. So the first and the fourth statement, that is myeloperoxidase action is mainly because of hypochlorous, is true. Next point, Shidiak-Higashi syndrome. Shidiak-Higashi syndrome. Shidiak-Higashi syndrome This is defective phagolysosome formation. That is, phagocytosis is taking place, but it is not able to bind with the lysosome. It is defective phagolysosome formation. Why? Because of defect in lysosomal transport protein. This occurs because of a defect in lysosomal transport protein called as the list protein. So Shinya-Higashi syndrome, defective phagolysosome formation because of a defect in list protein. As a result, phagocytosis is occurring, it is not binding to the lysosome. So the most characteristic feature of the disease is the presence of giant granules in neutrophils. Extremely important, please put a star on this. Whereas the most common feature is neutropenia. Please note, it is not neutrophilia. Neutrophils are not increasing, they are reducing. Next point, the gene involved in Shinya-Higashi syndrome is CHS1 present on chromosome 1. This is Shinya-Higashi. This gets us to our answer, that is Bruton's A gamma globulinemia. That is Bruton's A gamma globulinemia. A gamma globulinemia. First point, Bruton's A gamma globulinemia. This is a congenital immunodeficiency. Just a sec, let me correct the magnification. Bruton's A gamma globulinemia. This is congenital immunodeficiency. Congenital immunodeficiency of the B cells. First point. Next point, what happens in this? What is the molecular defect? The molecular defect is mutant tyrosine kinase. Molecular defect is mutant tyrosine kinase. As a result, it is associated with absence of B cells. B cells in turn leads to the synthesis of immunoglobulins. So there are very low immunoglobulin levels, which could result in defective opsonization, in turn leading to defective opsonization. This is Bruton's A gamma globulinemia. So if you just know that it is a congenital immunodeficiency of the B cells with absence of B cells, this in turn has very low immunoglobulin levels and defective opsonization. Next point, clinically, obviously if the opsonization is abnormal, it is associated with recurrent bacterial infections. Where? Especially of the respiratory tract. It is associated with recurrent infections of the respiratory tract, and that too by which organisms? Most commonly by pneumococci. Next, Bruton's A gamma globulinemia was an absence of B cells. So let us see one disease each. The most important ones associated with absence of T cells, which is Drug-Induced syndrome, and absence of both B and T cells, that is SCID. Let us have a look at those also. So this gets us to the next congenital immunodeficiency, that is Drug-Induced syndrome. Again, extremely important, Drug-Induced syndrome. This is a congenital immunodeficiency associated with absence of T cells. So this is opposite of Bruton's A gamma globulinemia. This is of the T cells. Next point, this occurs because of defective development. of the pharyngeal pouches. defective development of the pharyngeal pouches. Hence, it is not a genetic disease. It is not a genetic disease. I am not going into much details in this. So, the disease opposite of B is that of the T cells. Next, this gets us to the combined B and T cell deficiency, that is SCID, which stands for severe combined immunodeficiency, which stands for severe combined immunodeficiency, SCID. SCID, in this, both B and the T cells are abnormal. Both B cell and T cell functioning is deficient. It is deficient. Why? Why? This is because it is either because of defective interleukin 2 receptors, or defective kinases, defective interleukin 2 receptors, or defective kinases, or absence of MHC class 2 proteins, or ADA deficiency, that is SCID, severe combined immunodeficiency. So here our primary concern in the options were that of Bruton's A gamma globulinemia. Done. This takes care of question 73. This gets us to the next one, that is question 74. This gets us to question 74. Let us have a look at it first. Lady died with sudden pulmonary thromboembolism. Specimen of the liver is given. Most likely finding. This is an interesting question. I know the minute you saw this, majority of you were thinking of the answer as liver metastasis. Nahi bache. See, most common malignancy of the liver, metastasis. Agreed. So what you see here are numerous metastases, but correlate the full question. Lady died with pulmonary thromboembolism. So what happened was either HCC, hepatocellular carcinoma, or any other liver cancer, or any other cancer of the body which metastasized to the liver, and then it went to the lungs as metastasis, in turn leading to thromboembolism and death. So the answer is D, that is metastatic pulmonary embolism. Now the wording of option D, metastasis from pulmonary embolism, is wrong. It is metastatic pulmonary embolism. So question 74, the answer is D, that is metastatic pulmonary embolism. This was a tricky question. See, it is the answer, the best answer, it is not liver metastasis. I am laying stress on this again. Have a look. It can be any cancer or any carcinoma of the body which metastasized to the liver, that is liver mets, or it was a primary liver cancer, either liver metastasis or primary liver cancer, both, either of these can go as metastatic, they can metastasize to pulmonary vessels. That is called as metastatic pulmonary embolism, in turn leading to sudden death. So the answer is 4, that is metastatic pulmonary embolism. This was important and tricky. Please do not wrongly mark it as liver mets. That was wrong. Next, this gets us to the next question, that is question 75. Question 75. Let us first have a look at the question. Now what you have here, after surgery in scrotum, tumor specimen obtained is shown. What this shows is the presence of a homogeneous appearing tumor. It is homogeneous appearing with clear white areas with some area of hemorrhage. This is the classical presentation of a seminoma. This is the classical presentation of a seminoma. So, question 75, the answer is A, that is seminoma. Seminoma. So, before we go further, let us have a look at testicular tumors. The most common testicular tumor is a germ cell tumor. So testicular tumors, they are presumed to be germ cell tumors until proven otherwise. Why? Because more than 95% of all testicular tumors, more than 95% of all testicular tumors are germ cell tumors. Next point, how do we classify them? Germ cell tumors, they can be divided into seminomas and non-seminomatous germ cell tumors. Seminomas and non-seminomatous germ cell tumors. Non-seminomatous germ cell tumors, they are further of three types, that is yolk sac tumor, embryonal carcinoma, yolk sac tumor, embryonal carcinoma and choriocarcinoma. Yolk sac tumor, embryonal carcinoma and choriocarcinoma. Next point, best prognostic, seminomas. Best prognostic, seminomas. Worst prognosis, choriocarcinoma. Worst prognosis, choriocarcinoma. Choriocarcinoma, it's a very dirty looking tumor. It shows lots of hemorrhage and necrosis. Now point to be noted here is, I can further classify seminomas of the testis into two types. The classical seminomas, the classical and spermatocytic seminoma. This is important. I can classify seminomas of the testis into two types, classical or spermatocytic seminoma. First point, you very well know best seminomas have a good prognosis. So spermatocytic seminoma is a special subcategory of seminomas associated with an excellent prognosis. Associated with an excellent prognosis. First point. Next point, let us leave one line below this and then write the origin of testicular tumors. Origin of testicular germ cell tumors. Origin of testicular germ cell tumors is ITGCN. Origin or the precursor lesion. Origin or the precursor of testicular germ cell tumors is ITGCN. ITGCN stands for intratubular germ cell neoplasia. ITGCN, intratubular germ cell neoplasia. So, origin of all testicular germ cell tumors is ITGCN, except spermatocytic seminoma. Except spermatocytic seminoma. This statement again is important. Except spermatocytic seminoma, the precursor lesion of all testicular germ cell tumors is ITGCN. So, spermatocytic seminoma, first point we already saw that it has an excellent prognosis, and the next point is it is a tumor of uncertain histogenesis. It is a tumor of uncertain histogenesis. That is, we do not know the precursor lesion of spermatocytic seminomas. It is not ITGCN, it is a tumor of uncertain histogenesis. Next point, seminomas grossly, they are well demarcated. Grossly, we are now discussing seminomas only. They are well demarcated grey white tumors. Well demarcated grey white tumors with a homogeneous appearance. And this is what grossly seminomas look like. Grey white tumors with homogeneous appearance. Next point, microscopically, seminomas, they have large uniform cells. With distinct cell borders. Large uniform cells with distinct cell borders, that is, large cells, the cell borders are distinct, with presence of a clear glycogen rich cytoplasm. With a central round nucleus. This is the classical microscopy of seminoma. So what you will see in this are large uniform cells which are present in sheets with clear cytoplasm and a central nucleus. The cytoplasm is clear because of the presence of glycogen. So let us see what it looks like microscopically. This is the appearance of seminomas. It shows the presence of sheets of tumor cells with monomorphic appearance. Monomorphic is they have a similar looking appearance with round cells, central nucleus, clear cytoplasm. This is seminoma, an important microscopy. Next, this gets us to the next question, that is, just a sec, okay. So this gets us to the next question, that is question 76. It's an image based question. Let us just have a look at the image first. It shows the presence of, let's compare the size of the cells with an RBC. It shows the presence of large cells, about 2.5 to 3 times the size of an RBC, plus with presence of OR rods in the cytoplasm. So they are myeloblasts seen in AML, acute myeloid leukemia. Next point, even if I did not have any written question with this, the diagnosis was obvious, AML. Now let us have a look at the written MCQ. 40 female, fever and mucosal bleeding, it is fitting. High TLC, 1,57,000. High TLC, low platelet count. Cytogenetics, translocation 821. So in this case, you don't even need the image. Translocation 821, we have already discussed this in the good prognostic markers with AML ETO. That was seen in AML. So diagnosis is AML, acute myeloid leukemia. Next point. So question 76. Question number 76. The answer is A, that is AML. So before we go further, let us just document the two types of blasts and how do we classify them microscopically. First point, blasts, they are large cells about 2.5 to 3 times the size of an RBC. Please note I am comparing it with an RBC. Usually the comparison is made with a small lymphocyte because RBCs can be microcytic, normocytic or macrocytic. I am comparing here with an RBC because in the field you might not be able to see a lymphocyte. Next, they have a high nucleocytoplasmic ratio. Now there are two types of blasts, myeloblasts and lymphoblasts. So when a patient of acute leukemia comes to us, our primary aim is to differentiate a myeloblast from a lymphoblast. How do we do so? Let us make a table of the same. Starting with microscopy. Microscopically, the most characteristic feature of a myeloblast is the presence of all rods. This was what we were seeing in the image. The softer features are myeloblasts, they have a moderate amount of cytoplasm. Versus lymphoblasts which have a scant rim of cytoplasm. Next point, cytoplasmic granules. They are present in myeloblasts because the cytoplasm is more versus lymphoblasts where they are absent. Last point, nucleoli. Myeloblasts have multiple nucleoli which are again absent in lymphoblasts. This is myeloblast versus lymphoblast. Next point, we have already seen this is what myeloblasts look like. Large cells, moderate cytoplasm. Cytoplasmic granules, are able to make out the presence of granules with presence of all rods. Myeloblasts differentiated from a lymphoblast, which shows this is a lymphoblast, which shows the presence of large cells about 2.5 to 3 times the size of an RBC with scant cytoplasm, no granules, no nucleoli. So these are lymphoblasts seen in ALL, acute lymphoblastic leukemia, versus myeloblasts in AML. Next, this gets us to the next question, that is question 77. This gets us to the next one, that is question 77. Now, first let us have a look only at the image. What this shows you is the presence of cells which are slightly larger than an RBC with presence of hairy cytoplasmic projections. It is a hairy cell leukemia. We have already seen such a slide in the previous question. We have seen the features of hairy cell leukemia. We have done the markers and everything. This is hairy cell leukemia. Next point, hairy cell, which now before going further, let us have a look at the question. 55 male, fatigue, dragging sensation, low hemoglobin, TLC is low, platelet count is low. That is, the patient has pancytopenia. Hairy cell leukemia is present with pancytopenia. Bizarre looking cells, which stain will the pathologist use? Hairy cell leukemia is TRAP positive. So answer to question 77 is D. Question 77, the answer is D, that is TRAP positive. Hairy cell leukemia is TRAP positive. TRAP stands for tartrate resistant acid phosphatase. TRAP, tartrate resistant acid phosphatase. Hairy cell leukemia, TRAP positive. Next point, before we go further, let us continue this table of myeloblast versus lymphoblast. We saw that the differences between them microscopically were these. Now, but on the basis of microscopy, we will not always be able to differentiate a myeloblast from a lymphoblast. For that, we need special stains, that is cytochemistry. So, cytochemistry, let us see the stains that we use for myeloblasts versus lymphoblasts. It is the same table that we are continuing. Cytochemistry. Myeloblasts, they are MPO, that is myeloperoxidase. MPO, that is myeloperoxidase and Sudan black B positive. They are myeloperoxidase and Sudan black B positive versus lymphoblasts, which are periodic acid shift PAS positive. And what kind of positivity is seen with PAS? They are block positive with PAS. Block positive means if this is a lymphoblast, large cell high NC ratio with scant rim of cytoplasm. This is what lymphoblasts look like. We have seen that. Periodic acid shift, it is positive as a block inside it. It is positive as a block inside it. Block positivity with PAS. Next point, a special subtype of myeloblasts is monoblasts. A special subtype is monoblasts, which are NSE positive, non-specific esterase positive, which are NSE positive. In the previous question, we have already seen which are the monocytic leukemias, M4, M5. So NSE, it is predominantly positive in monocytic leukemias, that is M4 and M5. Hairy cell leukemia is TRAP positive. Hairy cell leukemia is TRAP positive. So 5 cytochemistries: MPO, Sudan black B, myeloblasts, NSE, monoblasts, PAS, lymphoblast, and hairy cell TRAP positive. Done. Next, this gets us to the next question, that is question 78. This gets us to the next one, that is question 78. First, again, let us have a look at the image. Always in the paper also look at the image in an unbiased manner. What you see here is the presence of numerous dark staining cells. So if it is staining dark, I am able to make out that this is some hemosiderin. Such a dark brown color is of hemosiderin. So most probably these are hemosiderin laden macrophages. I will not go further in this except hemosiderin laden macrophages. They are large cells with dark brown granules. Now let us have a look at the written question. What it shows is the severe respiratory distress, middle-aged male, severe respiratory distress, pedal edema, crepitations and auscultation, that's okay. Lung biopsy, what is your diagnosis? So many hemosiderin laden macrophages suggest the presence of heart failure cells. So question 78, the answer is D, that is heart failure cells. What do we mean by this? This, I am sure this was an easy one. What it means is the microscopically the lung biopsy showed numerous alveolar. It showed numerous hemosiderin laden macrophages. Microscopically there were numerous hemosiderin laden macrophages which are called as heart failure cells. Called as heart failure cells because they are associated with left-sided congestive heart failure. Associated with left-sided heart failure. These are the hemosiderin laden macrophages. I am sure you already knew this and majority of you would have gone right in it. Done. So this is question 78. Next, This gets us to the next one, that is question 79. Question 79. Now again let us have a look at the image first. What we see here is the presence of dilated structures. Let us be unbiased. I do not know the parent organ just by looking at this, though this is a classical image, but let us assume I do not know the parent organ. Still I am able to make out dilatations. I am able to make out the presence of dilatations which are localized to areas, and this other areas are normal. So now let us see at the question. Chronic smoker, for 15 years, respiratory distress. These 3 points are sufficient to make it as emphysema. Which type? Yesterday we saw the 4 types of emphysema: centriacinar, panacinar, paraseptal and irregular. Which is the one which has the strongest association with smoking? Centriacinar emphysema. Centriacinar emphysema. Now let us have a look at other options. Panacinar, chronic bronchitis, bronchiectasis. No, this is centriacinar emphysema. Next point. Before we go further, let us have a look at what it looks like grossly. Now look at this image. This is a much clearer view of the same image. What it shows are central areas surrounded by spared alveolar spaces. See, these dilated areas are all emphysema. They are all emphysema with spared alveolar septa or spared alveolar spaces. Spared alveolar spaces in surrounding area. So this is centriacinar emphysema. This is centriacinar emphysema, differentiated from panacinar emphysema, which involves the entire lung lobule. So this is panacinar. The whole lung lobule, the whole area is involved. Panacinar. Done. So have a look at the question image again. This was centriacinar with relatively spared areas in between. Here the lung is much darker because of carbon accumulation. He is a smoker. So answer to question 79 is A. Centriacinar emphysema. Centriacinar emphysema. We have already seen the types of emphysema and their associated features. Next, this gets us to the next question, that is question 80. Now again just look at the image. What we see here is the presence of malignant squamous cells with structures with arrows, that are the keratin pearls. So let us look at the written MCQ. 43 smoker male, growth in oral cavity. I need not even go further. Middle-aged male who is a smoker with growth in oral cavity, squamous cell carcinoma. Examination, patient was diagnosed with well-differentiated squamous cell carcinoma. The examiner has made it way too simple for you, making this as keratin pearls. So question 80, the answer is again A, that is keratin pearls squamous cell carcinoma. Next point. Before we go further, let us have a look at this image, because in the actual paper it might not be as easy as it was given here. Let us have a look at this image. Be unbiased about it. What you see here is the presence of normal stratified squamous epithelium. Normal stratified squamous epithelium, which is getting converted. All this is stratified squamous. This is the normal stratified squamous epithelium, which is changing to the tall columnar cells, in which nuclear polarity is maintained. nuclear polarity is maintained means the nuclei are present on one side of the cell. That is what we mean by nuclear polarity is maintained. So these are the columnar cells with presence of interspersed goblet cells. So stratified squamous changing to intestinal type. This is called as intestinal metaplasia, which is seen in Barrett's esophagus. So this is a base slide of Barrett's esophagus, intestinal metaplasia. Now, in this question, confusion arises because of the presence of these glands. Some of the students get confused that whether this is invasion or adenocarcinoma or not. No, have a look at the glands. Nuclear polarity is maintained. All the nuclei, they are present on one side of the cell. Differentiate this from this image, which again shows you the presence of glands. All these are the glands with hyperchromasia. The nuclei are darker and there is loss of nuclear polarity. Some nuclei are on top, some are on bottom. Differentiate these malignant glands from the benign glands. The appearance is totally different. So this is adenocarcinoma. I do not know the parent tissue in this. It can be of anywhere. So this is adenocarcinoma versus the squamous cell carcinoma with presence of keratin pearls. Versus squamous cell carcinoma with presence of keratin pearls. Done. So we have seen three things in this question. We saw squamous cell carcinoma with the keratin pearl, adenocarcinoma, and benign glands differentiated from adeno from Barrett's. Done. Next, this gets us to the next question, that is question 81. Identify the lesion and the special stain. All these, this is the classical microscopic appearance of plaques which are seen in Alzheimer's disease. Have a good look at this image. This has to be remembered. So, question 81. Question 81. The answer is plaques. What it shows you is a central core of amyloid. Plaques, microscopically, they show a central core of amyloid with a surrounding region. Central core of amyloid with surrounding region of dystrophic neurites. With a surrounding region of dystrophic neurites. This is a plaque which is seen in Alzheimer's disease. And the stain used for this is the Bilchowski stain. Done. This is Alzheimer's plaques. Next, this gets us to the next question, that is question 82. Just a sec guys. Okay. So this was Bilchowski stain with central core of amyloid with surrounding neurites. That is a plaque. This gets us to the next one, that is stellate granulomas with necrotic debris with neutrophils. Classical depiction of cat scratch disease. So starting with cat scratch, I'll show you what it looks like microscopically also. So question 82, the answer is D, that is cat scratch disease. So let us see why does it occur. Let us see this in slight detail. Cat scratch disease, this is an infectious disease. This is an infectious disease caused by bacteria Bartonella. It is caused by bacteria Bartonella Hensley. Caused by bacteria Bartonella Hensley. First point. Next point, why does it occur? Usually in children following scratch or bite from a cat. Following a scratch or bite from a cat. The name tells you that. Cat scratch disease. So the cat has scratched today. After how long the disease will occur? That is within 1 to 2 weeks. Within 1 to 2 weeks. Next point. Clinically, the patient shows tender swollen lymph nodes. The child shows tender swollen lymph nodes near the scratch or on the neck. So near the scratch or on the neck. So we can safely say that cat scratch disease presents as regional lymphadenopathy. It presents as regional lymphadenopathy. Next point. It is mostly a self-limiting disease. It is mostly a self-limiting disease. Self-limiting in what time period? Within 1 month. Self-limiting means that it resolves spontaneously. Next point, rarely it can have, we are all discussing clinical stuff here, clinical features here only. So rarely it can have neurologic or cardiac sequelae. It can show the presence of neurologic or cardiac sequelae like meningoencephalitis, encephalopathy, seizures or endocarditis. So rarely it can present with neurologic or cardiac sequelae also. That is meningoencephalitis, encephalopathy, seizures and endocarditis. Next point, this is then associated with a high mortality. Next point, coming to the main question, that is microscopy. Microscopically, it shows stellate granulomas. It shows the presence of stellate granulomas and a microabscess, with neutrophils. This is the classical presentation of cat scratch disease. We see stellate granulomas with debris and neutrophils. So before we go further, let us see what it looks like. This is the classical microscopic appearance of cat scratch disease. You have the presence of stellate granuloma with surrounding neutrophils. Have a look. This is what cat scratch disease looks like. This is cat scratch disease. Next, this gets us to the next question, that is question 83. Anaplasia. The name tells you everything. It is anaplasia is lack of differentiation. Changing of one epithelium to another is metaplasia. Nuclear chromatin changes, they are seen with reversible as well as irreversible damage, and so are the morphological changes. So anaplasia is lack of differentiation. An easy question, I'm very sure all of you would have marked it right, and nothing to explain in this. Lack of differentiation is called as anaplasia. Lack of differentiation is called as anaplasia. Next point, opposite of anaplasia is the extent to which the neoplastic cells resemble normal. That is called as differentiation. So lack of differentiation, anaplasia. Another two terms that are asked commonly are hamartoma. Hamartoma, it is a disorganized tissue. It is a benign disorganized growth. Benign disorganized growth indigenous to the site or at an ectopic site? Indigenous to the site. Benign disorganized growth indigenous to the site. What do we mean by this? Suppose liver. In liver, bile ducts are present in portal tracts. It's a well organized tissue. If dilated bile ducts are present in the liver in a haphazard manner, that is called as a hamartoma. Benign disorganized growth in the liver, indigenous to the site, hamartoma. Versus choriostoma. Chori karke it has gone to a different site. Versus choriostoma, in which the disorganized growth is present at an ectopic site. In which disorganized growth is present at an ectopic site. That is choriostoma. Next, this gets us to the next question, that is question 84. Question 84. Senile cardiac amyloidosis is associated with transthyretin. Easy, it is associated with transthyretin. So let us have a look at the other options one by one. Question 84, the answer is A, that is transthyretin. Transthyretin. So this gets us to amyloidosis. This was again a standard easy stat topic, amyloidosis. Let us see the type of amyloidosis with the protein associated. Starting with primary amyloidosis. Primary amyloidosis, it is associated with deposition of AL, amyloid light chain. Secondary amyloidosis, AA, secondary amyloidosis, amyloid associated protein. Next, hemodialysis associated amyloidosis. Hemodialysis associated amyloidosis, that is beta 2 microglobulin. Hemodialysis associated, which protein is getting deposited? Beta 2 microglobulin. Next, primary, secondary, hemodialysis associated. This gets us to the next category, that is hereditary amyloidosis. That is hereditary amyloidosis. There are three main hereditary amyloidosis, which are familial Mediterranean fever, familial Mediterranean fever, familial amyloidotic neuropathies, familial amyloidotic neuropathies, and systemic senile amyloidosis. And systemic senile amyloidosis. Systemic senile amyloidosis. These are the three hereditary amyloidosis, which is associated with deposition of AA, familial Mediterranean fever. It is the same as secondary amyloidosis, AA, and familial amyloidotic neuropathies and systemic senile with ATTR, which stands for transthyretin. Differentiate hereditary amyloidosis. These three were important. Differentiate hereditary amyloidosis from localized amyloidosis. Differentiate it from localized amyloidosis. Localized amyloidosis is senile cerebral amyloidosis. Senile cerebral amyloidosis, which is the Alzheimer's disease associated with deposition of A beta. So do not confuse beta 2 microglobulin of dialysis associated with ATTR, systemic senile, with A beta of Alzheimer's. The next localized amyloidosis is medullary carcinoma thyroid. Medullary carcinoma thyroid with deposition of ACAL. Next, type 2 diabetes. Type 2 diabetes associated with AIPP. AIAPP, that is islet amyloid peptide. That is islet amyloid peptide. IAPP, islet amyloid peptide, type 2 diabetes. And the last is atrial amyloidosis. Last is isolated atrial amyloidosis. Isolated atrial amyloidosis, which in turn is associated with AANF, that is atrial natriuretic factor. Atrial natriuretic factor. Atrial amyloidosis, ANF, atrial natriuretic factor. These are the amyloidosis. These are the types of amyloidosis. So we divided into three types: primary, secondary, hemodialysis, hereditary and localized amyloidosis. Next, this gets us to the next question, that is question 85. This gets us to the next one, that is question 85. T cell interleukins are all except interleukin 1. Interleukin T, interleukin 2, 4 and 5, they are of the T cells. Interleukin 1 is not. So question number 85, the answer is A, that is interleukin 1. Let us see 1-2 points with this. It is the most potent pyrogen. It is the most potent pyrogen. Interleukin 1 has been asked so many times that now they have stopped giving the option of interleukin 1 with pyrogens. So which is the next most potent pyrogen? Followed by interleukin 6. If this is also not given in the options, the next is PGE2. Next point, interleukin 1. It is secreted by macrophages. Secreted by macrophages. Done. Whereas the others, interleukin 2, 4 and 5, they are secreted by the T cells. So they are T cell mediated. Next, let us have a recap of this again. Interleukin 5, most potent role in eosinophils. Next point, pyrogen we have already seen. Next, last question, main role in sepsis. Main role in sepsis, TNF alpha. This again is asked. Main role in sepsis, TNF alpha. Done. Add one more point. Main cytokine involved in ARDS, acute respiratory distress syndrome, interleukin 8. ARDS, acute respiratory distress syndrome. This is non-cardiogenic pulmonary edema, interleukin 8. Last point, whole pathogenesis of multiple myeloma. It is which cytokine overexpression? Interleukin 6. Interleukin 6. So multiple myeloma, interleukin 6 overexpression. These are the miscellaneous other questions associated with it. Next, this gets us to the next question, that is question 86. This gets us to the next one, that is question 86. Cystic fibrosis, inheritance pattern, autosomal recessive. The examiner in the paper will not give you that it is autosomal recessive. You have to remember it. Cystic fibrosis, chromosome 7, autosomal recessive. Now, a normal couple has one daughter affected with the disease. They are now planning to have another child. What is the chance of her sibling being affected? Easy. 1/4. C. The answer is C, that is 1/4. Nothing, it is extremely easy. Let us assume the wild type allele. The wild type allele. Wild type means normal or abnormal. Normal is capital C. The abnormal allele is small c. This is I can give it anything. I'm just giving it this. So the question is, a normal couple has one daughter affected. Couple is normal means both the mother and the father are heterozygous. It was autosomal recessive condition, so they will not manifest. So what are the combinations possible? CC, CC, CC and CC. What is the chance of the sibling having the disease? It is 1/4. Chance of sibling having the disease is 1/4. Simple. Next point, cystic fibrosis. It is inherited. It is inherited as an autosomal recessive disease present on chromosome 7, and the gene abnormality associated with this is the CFTR gene. Gene abnormality, CFTR gene. CFTR stands for cystic fibrosis transmembrane regulator gene. Gene abnormality, CFTR. Cystic fibrosis transmembrane regulator gene. Cystic fibrosis transmembrane regulator gene. That is the CFTR gene. Next, this gets us to question 87. This gets us to the next question, that is question number 87. Now, all are true in Fragile X, repeatedly asked. They have a large head, large ears and large testes. What is not large as nose. So just touch your nose once and you will forever remember it. It is not associated with a large nose. So before we go further, let us see Fragile X syndrome in detail. First point, Fragile X syndrome. It is a disease of non-Mendelian inheritance. It is a disease of non-Mendelian inheritance, which is inherited as trinucleotide repeats. What do we mean by this? 3 nucleotides are getting repeated multiple times. Trinucleotide repeats. First point, let us go sequentially. Fragile X syndrome. Before we go further, tell me which is the most common genetic cause? Most common genetic cause of mental retardation. Answer, most common genetic cause of mental retardation, Down syndrome. Please note, the most common genetic cause of mental retardation is Down syndrome, followed by Fragile X syndrome. So Fragile X, it is the second most common genetic cause of mental retardation. Next point, the gene involved in Fragile X syndrome is FMR1 gene, which is the familial mental retardation 1 gene. FMR1, that is familial mental retardation 1 gene. FMR1 gene. Next point, which trinucleotides are getting repeated? Which trinucleotides? Easy to remember. the patient is mentally retarded, so he has kam gyan. The Hindi speaking population, you will be able to know this, kam gyan. So the trinucleotides are CGG. What do we mean by this? Normally all of us, we have 30 to 60 CGG repeats. That is CGG, CGG, CGG. In this way it is repeated 30 to 60 times. Then there is a pre-mutated state. Where these are 300 to 400 repeats. And lastly, a mutated state where they are 3000 to 4000 repeats. Normal, pre-mutated, mutated. I am not interested in the number of repeats, but what I am very much interested is when is the mutation increasing. Extremely important, the mutation increases at oogenesis. What does this mean? If the mother is in a pre-mutated state, her child will be in a mutated state. And this principle, so what is the principle? Increasing severity of disease with successive generations. Increasing severity of the disease with successive generations is called as anticipation. This principle, that is increasing severity of the disease with successive generations, is called as anticipation or Sherman's paradox. It is called as anticipation or Sherman's paradox This is Fragile X syndrome. Last point, clinical features. Clinically, obviously it is associated with mental retardation. That is obvious. The other features are, in this everything is large forehead, large jaw. It is also called as macrognathia. Large jaw, large ears, and large testes. That is macroorchidism. Large testes, macroorchidism. This is the most characteristic feature of the disease, macroorchidism. Next point, repeatedly asked, what is not large? Nose of the patient is not large. So just touch it once and you will forever remember it. Done. This is Fragile X syndrome, trinucleotide repeats. Next, this gets us to the next question, that is question 88. Question 88. Increasing severity of mental retardation of male members over generation is a result of trinucleotide repeats. We have already seen this. Trinucleotide repeats, it is associated with anticipation. Successive generations is showing increased severity of the disease. We have seen this. Next, this gets us to the next one, that is question 89. Question 89. HLA associated with rheumatoid arthritis is HLA-DR4. HLA-DR4. So let us make a table of diseases associated with various HLA. So HLA-DR4, we have already seen this is associated with rheumatoid arthritis. Next point. Next, let us go sequentially, starting with everybody's favorite, HLA-B27. Starting with HLA-B27, seen in ankylosing spondylitis, ankylosing spondylitis, reactive arthritis, ankylosing spondylitis, reactive arthritis, Ritter's disease, reactive arthritis, Ritter's disease, and psoriatic arthropathy. Ritter's disease and psoriatic arthropathy. This is HLA B27. Next, HLA DR2. Next, HLA DR2, Goodpasture's syndrome. HLA DR2, Goodpasture's syndrome, and multiple sclerosis. And multiple sclerosis. Next, HLA DR3. HLA DR3, Sjogren's syndrome. HLA DR3, Sjogren's syndrome, and lupus. Next, HLA DR4, rheumatoid arthritis. We have already seen that. Next, HLA DQ2 and DQ8. HLA DQ2 and DQ8, celiac disease. DQ2 and DQ8, celiac. Celiac was gluten sensitive enteropathy. Next, HLA B5. HLA B5, it is associated with Behçet's disease. Behçet's disease and ulcerative colitis. Behçet's disease and ulcerative colitis. Next, whatever else you can think of, that is HLA DR2, DR3, DR4, DQ2, everything, it is associated with type 1 diabetes. Associated with type 1 diabetes. These are the HLAs associated with various diseases. Unfortunately, this has to be memorized. Next, this gets us to the next question, that is question 90. This gets us to the next one, that is question 90. Genomic imprinting. We have already seen this in detail yesterday with all the clinical features and everything. Paternal 15 deletion. Remember, paternal imprinting is Angelman, maternal imprinting is Prader-Willi. Paternal deletion, let me write it for you. Prader-Willi and Angelman, let me just write it for you in one go. Paternal deletion is Prader-Willi. Firstly, let us see the answer. It is option B. It is question 90. The answer is B. That is Prader-Willi syndrome. We have already seen this in detail. So, just a quick recap. Prader-Willi is maternal imprinting plus paternal deletion. It is maternal imprinting plus paternal deletion. Or it is maternal disomy. We have seen this in detail yesterday. Versus Angelman syndrome. Versus Angelman syndrome, which is paternal imprinting plus maternal deletion, or paternal disomy, or paternal disomy. We know this. Next, this gets us to the next question, that is question 91. This gets us to question 91. True about proto-oncogenes. They are important for normal cell growth. This is true. c-Myc overexpression causes lymphomas. No. Next, mutations cause retinoblastomas. No. Deletions cause sickle cell disease. First point. Let us go point-wise. Mutations cause retinoblastoma. Retinoblastoma, it is caused by mutation in tumor suppressor gene, not in proto-oncogene. So this is false. Next, sickle cell disease is by a point mutation, not deletion. Not deletion. Next point, lymphomas, they are not caused by c-Myc overexpression, they are caused by c-Myc mutations. So the answer is A. The answer is A. That is, they are important for normal cell growth. They are important for normal cell growth. Proto-oncogenes, important for normal cell growth. So let us see about proto-oncogenes. First point, they are proto-oncogenes, they are expressed normally. Proto-oncogenes, they are expressed normally. They are expressed normally and have multiple rules related to normal growth. Multiple rules related to normal growth and proliferation of cells. Related to growth and proliferation of cells. Next point, mutations in proto-oncogenes are associated with various tumors. So starting with oncogenes involved in cancers, starting with the RET proto-oncogene, RET proto-oncogene mutations is associated with MEN syndromes, multiple endocrine neoplasias, MEN syndromes. Next are the KIT proto-oncogene mutations, which are associated with GIST, CKIT, GIST, gastrointestinal stromal tumors, GIST and seminomas. Next, the Gtp binding mutations. Gtp binding mutations, I can divide them into three types. KRAS seen in colon, lung and pancreatic tumors. KRAS, colon, lung and pancreatic tumors. HRAS, that is bladder and kidney tumors. And the last one is NRAS, which is melanomas and blood cancers. So GTP binding mutations, KRAS, HRAS, NRAS. Next, it is associated with beta-catenin mutations. Beta-catenin, hepatocellular carcinoma, HCC and hepatoblastoma. What we are studying are the various proto-oncogene mutations, beta-catenin, HCC and hepatoblastomas. Next, MYC mutations. c-Myc, that is c-Myc translocation. Please note it is not overexpression. c-Myc translocation, Burkitt's lymphoma. The option asked you overexpression. It is not overexpression. It is c-Myc translocation versus n-Myc amplification or overexpression. n-Myc, which is neuroblastomas and small cell carcinoma lung. n-Myc, neuroblastoma and small cell carcinoma lung. And last is L-Myc amplification, which is again small cell carcinoma lung. So point to be noted is c-Myc is translocation, n-Myc and L-Myc are amplifications. This is asked. Next, cell cycle regulators, that is the proto-oncogenes. small cell cyclin D1 expression seen in mantle cell lymphoma. Cyclin D expression, mantle cell lymphoma, breast and esophageal cancers. Breast and esophageal cancers versus cyclin E overexpression versus cyclin E, which is in breast cancer. These are the proto-oncogene mutations. Retinoblastoma, this is a mutation in tumor suppressor gene. It is a mutation in tumor suppressor gene, not proto-oncogene. It is a mutation in tumor suppressor gene, not proto-oncogene. Please note this. And it RB gene present on chromosome 13. Short arm, long arm, chromosome 13q. Next, so answer to question 91 is A. CMYC overexpression नहीं होता. It's not overexpression, it is translocation causes lymphomas. RB gene is not a proto-oncogene tumor suppressor, and sickle cell anemia is not a deletion, it is a point mutation. Next, this gets us to question 92. SYT-SX gene is associated with synovial sarcoma. It is associated with synovial sarcoma. So question 92, the answer is C, that is synovial sarcoma. First point, what do we mean by this? So this, let me rephrase it. This gets us to the translocations associated with various tumors. Starting with Ewing sarcoma. These lists, unfortunately, they have to be remembered. Ewing sarcoma, it is translocation 1122, which is the most common, that is FLI1 EWS fusion gene. Next is translocation 2122. So 1122, 2122, that is ERG EWS gene. Remember these two main ones, sufficient. Ewing's 1122, 2122. Next is synovial sarcoma. That is translocation X18. This was what was asked. SYT-SSX fusion gene. Next, clear cell sarcoma. We are writing the important ones, that is translocation 1222. Remember 22 has EWS, so this is EWS ATF1 gene. Next, you very well know the translocations associated with AML, the good prognostic ones, that is translocation 821, translocation 1517, and inversion 16. You know their associated fusion transcripts also, that is AML ETO, also called as RUNX1 T1. We've already written this, 1517 PML RARA, and inversion 16, that is CBFB MYH 11. You also know the two translocations associated with ALL. acute lymphoblastic leukemia, which are translocation 1221, fusions transcript tell AML, which is associated with a good prognosis, and translocation 411 fusion transcript MLLAF4, which is associated with a poor prognosis. These are the translocations with ALL, with their associated fusion transcripts, and AML, which are all the good prognostic translocations. This list of translocations with their fusion transcripts unfortunately has to be remembered. Next, this gets us to the next question, that is question 93. Just a sec, guys, let me restart this. This gets us to the next one, that is 93. Okay, so most important prognostic indicator of mesenchymal tumors is not the type, not the size or site, it is the grade of tumor. That is obvious. Question 93B. Question 93. The answer is B. That is grade of the tumor. This is the most significant prognostic marker associated with prognosis in mesenchymal tumors. So what do we mean by grade of the tumor? Grade, it is based on degree of differentiation. Grade of the tumor, it is based on degree of differentiation. Number of mitosis per high power field. High power field is 40x. This can again be asked. Scanner 4x, low power field 10x, high power field 40x, oil immersion 100x. So number of mitosis per high power field. Cellularity, pleomorphism. Pleomorphism is the variations in size of the cells and the nuclei. Pleomorphism and necrosis. All these components come under grading of the tumor, and this is the main factor, main prognostic indicator for mesenchymal tumors. Next, this gets us to the next question, that is question 94. This gets us to the next one, that is question 94. The following agents are known as leucomogens except benzene is, ethylene oxide is, ionizing radiations are. The answer is B, that is beryllium. This is not a leucomogen, or not a one which is a carcinogen. Beryllium. So let us make a list of various leukemogens. The various leukemogens are, this unfortunately again has to be remembered, they are benzene, ionizing radiation, ethylene oxide. These first three, they were given in the options only. Benzene, ionizing radiation, ethylene oxide, melphalan, melphalan, cyclophosphamide, melphalan, cyclophosphamide, phenylbutazone, cyclophosphamide, phenylbutazone, and chlorambucil. These are the various leukemogens. So you need not rectify this, just have a look at the list once or twice and you will remember everything about it. Next, this gets us to the next question, that is question 95. This gets us to the next one, that is question 95. Leptocytes in blood smear. Leptocytes is another name for target cells. So target cells in blood smear are seen in thalassemias. Question 95B. The answer is thalassemia. Thalassemias. So before we go further, let us have a look at this. Leptocytes, they are also called as target cells. Leptocytes or target cells which are seen in thalassemias. So before we go further, let us look at morphological abnormalities in RBCs. Starting with the first point, you very well know anisocytosis is altered size या shape. Anisocytosis is altered size. Poikilocytosis altered shape of the RBC. So coming to the morphological abnormalities, starting with the first one, that is echinocytes or Burr cells. It shows spicules on RBC surface. Echinocytes or Burr cells, spicules on RBC surface which are of equal size and are equally spaced. Spicules on RBC surface, equal size and equally spaced. This is the most common artifactual change. Is seen in RBCs. Artifactual means there is no problem in the RBC. While making the slide, they were seen. Echinocytes or Burr cells. Differentiate these from acanthocytes. Or spur cells, which shows spicules on RBC surface which are unequally spaced. Spicules on RBC surface which are of unequal size and are unequally spaced. These are seen in liver diseases and A beta lipoproteinemia. Acanthocytes or spur cells. Next, the next is the presence of bite cells, which along with Haynes bodies are seen in G6PD deficiency. I'm very sure you already know what a bite cell looks like. It is a cell which is an RBC which is bitten. This is what it looks like, a bite cell, G6PD deficiency. Next is spherocytes. Seen in hereditary spherocytosis and autoimmune hemolytic anemia. Spherocytes. How do we identify a spherocytes? They lack the central pallor. Next, basophilic stippling. Please put a star on this. This is important. Basophilic stippling seen in lead poisoning. Now this has been asked so many times that now they have stopped giving the option of lead poisoning. So if this is not given, the next best answer is thalassemia followed by megaloblastic anemia. So basophilic stippling, lead poisoning, thalassemia, megaloblastic anemia. Next is Pappenheimer bodies. Pappenheimer bodies which are seen in sideroblastic anemia. Pappenheimer bodies, sideroblastic anemia. Next, Howell-Jolly bodies. Howell-Jolly bodies and Cabot rings. Howell-Jolly bodies and Cabot rings, megaloblastic anemia. Megaloblastic anemia. Other than this, they are also seen post splenectomy. Howell-Jolly bodies and Cabot rings, megaloblastic anemia, and post splenectomy. We have already seen these abnormal morphologies numerous times, so I'm not showing them to you again. Have a look. These are the morphologies with the diseases. Howell-Jolly bodies, they are also associated with thalassemia. The last and the most important is schistocytes. Schistocytes, which are seen in MAHA. MAHA stands for microangiopathic hemolytic anemia. MAHA, microangiopathic hemolytic anemia. Schistocytes, they are seen in MAHA, microangiopathic hemolytic anemia. So what are the causes of MAHA? MAHA, it is associated with DIC, HUS, hemolytic uremic syndrome, TTP, thrombotic thrombocytopenic purpura, TTP. Next, march hemoglobinuria. The soldiers, they march hemoglobinuria. HELP syndrome, hemolytic anemias, elevated liver enzymes, low platelets. Hemolysis, elevated liver enzymes, low platelets, seen in pregnancy, hypertension with pregnancy, that is preeclampsia. Next, it is also associated with deficiency of complement factors. Deficiency of complement factors B, H and I. Deficiency of complement factors B, H and I. And the last cause of MAHA is PNH. These are the diseases associated with MAHA. Microangiopathic hemolytic anemias. Done. This gets us to the next question, that is question 96. This gets us to the next one, that is question 96. Direct Coombs test is positive in all except aplastic anemia, it is not positive. Drug-induced autoimmune hemolytic anemia, agreed. Hemolytic anemia due to transfusions and hemolytic disease of the newborn. In BCD it is positive, not in aplastic anemia. So question 96, the answer is A, that is aplastic anemia. The answer is A, that is aplastic anemia. So first point, direct Coombs test. This detects the presence of antibodies. On RBC surface. First point, direct Coombs test, it detects the presence of antibodies on RBC surface. First point. Next point, diseases associated, where all is direct Coombs test positive? See, differentiate between direct and indirect. Direct Coombs test detects the presence of antibodies on RBC surface versus indirect Coombs test, which detects antibodies in serum of the patient. So antibodies on RBC surface direct, indirect is antibodies in serum. Next point, diseases associated with direct Coombs test. They are, of course, autoimmune hemolytic anemia, AIHA. Next, drug-induced hemolytic anemia, that is drug-induced immune hemolytic anemia. Diseases associated, autoimmune hemolytic anemia, drug-induced immune hemolytic anemia. Next, hemolytic diseases. Next, hemolytic diseases. Let me write it properly. Hemolytic diseases of the fetus. Hemolytic diseases of the fetus and newborn. Of the fetus and newborn. Next, hemolytic transfusion reactions. Hemolytic transfusion reactions because of antibodies. Because of antibodies. And the last is SLE. And the last is SLE. These are the diseases. Please note, in SLE, this SLE need not be associated with hemolytic anemia. As such, also it may be associated with a direct Coombs test. So these are the diseases associated with direct Coombs test, which detects the presence of RBCs on, which detects the presence of antibodies on RBC surface. So it is not seen in aplastic anemia. Next, so this takes care of question 96. This takes care of question 96.